by the Hawaii Consortium for Continuing Medical Education, a joint venture between the Hawaii Medical Association and the Johnny Burns School of Medicine. Evaluation forms were distributed at the sign-in table. Your comments are very important to the planning committee and will be used to plan future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy. Speakers are expected to disclose to the audience any real or apparent conflicts of interest that may have a direct bearing on the subject matter of the program. Drs. Yi and Imamura have disclosed that they have no relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. So a little bit about our speakers. Dr. Sarah Lynn Yi is a local girl and graduate of the Johnny Burns School of Medicine, whose residency was at Santa Clara Valley Medical Center and fellowship with the University of Hawaii Johnny Burns School of Medicine Geriatrics Department. She has professional experience at Kaiser Santa Teresa as a nocturnist, hospice, as well as a hospice at Queens Medical Center West, with the privilege of being there at the beginning when it first opened. She has since transitioned to the geriatrics team at Queens Medical Center and has an interest in building better transitions of care, including quality improvement projects such as the Geriatric ER certification for all Queens facilities. Dr. Taichi Imamura graduated from Hokkaido University School of Medicine in Japan. He completed his emergency medicine residency in Farmington, Connecticut. He started to work at the Queens Medical Center Punch Bowl and West in July 2017. He became partner of the emergency group in July 2018 and became the lead physician in the Geriatric ER Accreditation project at Queens Medical Center since September 2018. Please help me welcome Drs. Yi and Imamura.
Hi, I'm Taichi Imamura from Emergency Department. Thank you for this great opportunity to let us talk about our Geriatric ER Accreditation project today. Okay. All right, so today we're gonna talk about the oncoming silver tsunami and the geriatric ER certification process, and a brief study of patient outcome between pre-accreditation phase versus post-accreditation phase. So I will introduce the statistics of our geriatric population first, and then Sarah will share the process of accreditation and strategy to work through some roadblocks in accreditation process. Then I will close with study result. All right, silver tsunami. So what does this mean to us? 48 million of people are age 65 or older in the United States, which is approximately 7% of the total population. Hawaii has higher aging population. Actually, we have 13,000 people are 65-year-old or older, which is 16% of the total population. The fastest growing population is those of 85-year-old or older, which is growing at the rate of 3 times of the general population. So we are getting older very fast. Geriatric patient requires more medical resources. In 2013, nationally, 43% of hospital admissions and 48% of ICU admissions are for geriatric patients. We already know 7% of American population are geriatrics. So that being said, about half of the pie was eaten by this only 7% of population in the United States. Geriatric patient also, compared to young population, geriatric patient also require 20% longer hospital stays and 50% more laboratory tests and imaging services. And amazingly, they are 400% more likely to require social services. So geriatric patient requires lots of medical resources. I was born and raised in Japan, and I used to work in the emergency department in Japan. But I can say Japan is at the forefront of silver tsunami. And Japan has the highest number and rate of aging society in the world and the history. But we can also see there is rising tide also building in Hawaii and the US as well. So one day when I was working in the emergency department, I took a screenshot of Queens ER patient tracking board, and then I counted how many of our patients are geriatrics. The patient with the red circles are geriatric patient, which means 65-year-old or older. So 33% of total ER populations were geriatrics for this day. So we have lots of geriatric populations. But I was just curious what's going on in the emergency department in Japan, which has the highest aging population. So one day, I asked my friend who is working in the emergency department in Japan, and asked him to send his ED patient track board. Then I used to work here, so I know the severity of disease and volume of patients are very similar to Queens ER. So, sorry, it's all Japanese, but so a blue, the blue column is like it's a very critical patient, cardiac arrest patient. Red, like meaning emergency patient, meaning like STEMI or stroke. Yellow is urgency, so abdominal pain, slight tachycardia, chest pain, history of diabetes. Those are like yellow patient. Green patient, cough, runny nose, stable vital sign, non-urgent patient. Gray patient are basically medication refill, not emergency at all. So pretty much similar to Queens ER populations. However, only difference is age. So you can see the number with like a red circle from top, 66, 87, 70, and then like 94, 87. Those are all geriatric patients. 2 out of 3 are geriatric patient in this day. So Hawaii, 16% of total population are geriatrics. In Japan now, 27% of total populations are geriatrics. So I anticipate, because Hawaii's population is aging fast, so Hawaii will see today's Japan's geriatric situation in the next 10 to 15 years. So definitely silver tsunami is coming from Japan and crashing into Hawaii in the next 10, 15 years. So we have to do something. This is the data from Queens ER. So we are already seeing the aging trend in our patient populations. This is data from Queens Punchbowl ER. In 2015, geriatric patients were only, not only, 23.9%. But last year, the ratio increased to 26.7%. In the only past 4 years, we can see significant increase in geriatric populations. And then geriatric population requires longer ED lengths of stay. And then bottom column, ED lengths of stays are also increasing. And as we know, longer ER lengths of stay can lead to poorer patient outcomes, such as delirium and decubitous ulcer or like loss of physical functions. So Queens West has a similar trend. In the only past 4 years, we can still see significant increase in geriatric population in the emergency department. And length of stay in the Queens West is getting shorter thanks to leadership incentives. Very recently, ACEP, American College of Emergency Physicians, which is the largest emergency medicine organization in the country, started this geriatric emergency department accreditation program to improve patient care and awareness of ER staff of this geriatric patient. And 21 hospitals immediately applied for this program, and now 260 hospitals have been waiting for accreditation site visit. So I believe the value of this accreditation will grow in the future, and it will be more competitive to obtain this certification. Okay, so now Sarah will talk about the actual process of geriatric ER accreditation.
Hi, so I'm going to talk a little bit about the process of the geriatric ER accreditation. I'm not going to go into the details of like what protocols we chose or how many we chose, simply because that can be found on the ACEP GETA website. So what I wanted to talk a little bit more was the formative process of how we went about doing this and some of the potholes that we encountered over the time of the accreditation and how we troubleshot some of those problems. So to just give a general overview though, is that there's 3 different levels of certifications. The website does offer, I think, close to 30-ish or 28-ish different options of what you can choose to focus on in terms of your protocols. And there's different levels based off of how many protocols you can develop. So the gold is 20 protocols plus education plus changes in physical environment. Silver is 10, and bronze is actually not any protocols, but actually an initiative that the facility wants to focus on that will improve the quality of care to the geriatric population. So actually, Punchbowl has gold certification. We're the 5th in the nation to attain gold certification. West is the first in the nation to attain silver, and Molokai General in North Hawaii has bronze. So we did all 4 at the same time. So Taichi initially approached our team, I think, back in May-ish or so. So he actually didn't give himself enough credit. So he came to our geriatrics monthly meeting and proposed this idea because he felt very passionate that in the future we will have to pay closer attention to our geriatric populations in the ER because they're at higher risk, and the number of encounters that we're seeing in the ER is higher. So what we did is we actually, he and I got together, we discussed, what level of certification that we felt we should go for, and then we reviewed the different protocol options and selected which ones would be good for our facilities. We drafted out all of the protocols, and then we said, okay, we think we've done a good thing, and we're going to approach the ER, and it's going to be easy because we just did it. We did the majority of the work. When we went to the different ERs and talked with the ER administration, as well as West, as well and Punchbowl, this was the response we got. Oh my gosh, this is overwhelming. You're telling us that we have to do 20 different protocols. What are we actually changing? We're just completely overwhelmed. And it was a good lesson when I reflected back on it that even though we went through and we processed out all of our protocols, we actually didn't involve the players who were the most important from the get-go, and that's why we had the response of. So what we did was, the first thing we noticed is that there was a problem with engagement, and that being that in the ER, there are so many different moving pieces, and there's so many different certifications. We have stroke certification, we have level 1 trauma certifications, we're worried about the Joint Commission requirements, and then it was, when will we have time for geriatrics? How will this affect my workload? So unfortunately, yes, it will affect your workload. It will make it a little bit more time consuming because our elderly populations need a bit more time, but we needed to explain why this was important. And actually, Melissa, who's sitting in our crowd, as well as Patty, they really helped with engagement, as well as emphasizing why this matters to us and why it's important. So in terms of engagement, we had to take ownership of the project, making it our own. So earlier on in the slides, I did highlight education. So education was really important because without education, you wouldn't get people knowing about the project that you wanted. What we did was we involved Patty's mother. She's actually a patient of our clinic, and we opened up our speeches with a quote from her mom. And her mom is actually a part of our committees. She's actually our community liaison who provides us feedback on what could be improved. So when the ER staff started to see that these aren't just old people or anyone's old person, they started to see that this is my mom, these are my parents, these are my grandparents, this is my uncle. It started to become important to them. And as a result, to kind of, get an idea of how things were in the forefront, because a lot of these protocols are actually not carried through by physicians. They're carried through by the nursing staff. So they're doing the majority of the work for this project. We also have nurse champions at every facility who partake actively in education, as well as giving us real-time feedback on what's working and what's not working in our interfaces and protocols. We also pushed alignment with our mission, which is why I put up a screenshot of our poster of what it means to be the Queen MOA. Because if you have a mission that kind of encompasses that you can bring it in, it actually makes people realize why this is important to not only them, but to their organization as a whole. So roadblock number 2. So with any project that is geriatric focused, it's multidisciplinary. So we had all these moving pieces and moving players. Pharmacy, IT, physical and occupational therapy. I did discuss how the nursing staff played a huge role, but also social work, because the elderly are more likely to utilize 400% or more social work resources. So you want to get them brought in earlier, as well as physicians and admin. And we had to figure out how to gather data and outcomes, which Taichi will talk a little bit more about later. So what we did is we utilized the strength of our different players. We met with pharmacy early. They wanted a screening program or a criteria for which you would screen elderly for inappropriate use of medications, and we decided pretty early that beers would be a bit cumbersome. But instead what we did was the pharmacist applied for a grant. So we now have a pharmacy tech that does med reconciliations in the ER. As I mentioned before, we had our nurse champions who teach our staff, but we also had education sessions which had practical approaches as well. So we invited physical therapy and occupational therapy in to teach practical sessions with use of gait belts, how to properly align your walkers and your canes to improve mobility, because that's part of the project as well. And then we found social work experts in our field so that we could tie them in, because we're very blessed in the sense that we have someone who's in our clinic who has an interest in elder care from the social work standpoint, and we brought her into our social work meetings so that we could help provide more education on access to resources and such for all of the social workers in the ER. We also approached the admin early. We actually, I think, we tried to appeal to, I think we were trying to see if we could get like a grant to help fund some of our accreditation. It was a nice try. It didn't work, but at least we tried that route. And we also engaged IT early and regularly to make sure that the changes were in place, and actually Danny spearheaded a lot of that. So I do appreciate that he was able to move IT along, because sometimes that could be a rate limiting step in this process. So now I'm going to shift the focus a little bit more onto education and how we went about educating the staff, because you do have to show that your champions, you have to show a physician lead as well as a staff lead, like a nursing staff lead, and that they have trained and have focus on education in geriatrics. So even though the requirement was just one person, we actually educated very broadly within our staff, and I think that was a huge process and project for coordination. So I appreciate Melissa and Cheryl, who are our clinical nurse educators for both ERs at Punchbowl and West, and they actually drew in our other facilities into the process so that everyone was engaged. So for the physicians, we offered all the ER MDs Geri EM, which is actually a free website in which they can watch videos, and I actually did a few of the modules. So they show you the wrong approach, and then they say, well, these are the things that could be improved, and then they show that it actually only takes maybe 30 seconds or less to improve the interview and how to interact with your patients. And you can apply to get CME credit from it. It's a Canadian-based website. And even though we only needed one ER champion, 90% of the ER physicians at West and Punchbowl completed the Geri EM module. For the nursing education portion, we actually did purchase the GENE module for our champions at all 4 facilities. And this one, actually, we got good feedback from our nursing staff that they really liked it, because it was different in how it approached things from the physician standpoint. This one was more systems oriented, and they could go through different topics by system. And when they completed the training, we had all of our nurse champions then go and build learning modules. So, oh shoot, the slide, oh there, here. So they built learning modules, and we held education fairs to kind of disseminate the information to the rest of the staff. So we had our nurse champions choose a topic that they found interesting. And based off of that, they built PowerPoints that we then distributed to the rest of the ER staff. And I was actually consulted to kind of review these slides to make sure they were okay. And then in the education fairs, we actually had more, I guess, in a sense, learning as well as the practical. So that's when we brought in physical therapy to do the gait belt training, and then we brought APS in so that they could learn more about their roles, as well as we brought in advanced care planning. And we're in the process of working through our next education fair, and we always want to have a practical portion of the education fair that can be utilized by all members of the staff, so like even the CNAs, and not just nursing staff. So from this process, I learned that sometimes I didn't always see eye to eye with the ER doctors and the ER team, but we were able to work through things, and I think with a bit of patience, we'll continue to get there. And now I'm going to pass it on to Taiichi to talk about our outcomes. Oh, wait, no. Oh, I'm talking about the workflow. Okay, so to just generally go over some of the things about the workflow, we felt that these protocols were good because they identified the population early in the ER stay, and they institute protocols to kind of standardize and streamline care. And we're hoping that when we transition people back to the community, it provides access to more resources. So what actually happens, and even though I know that geriatrics is not based solely on age, it's more about your conditions and functional status, we had to say, well, at this point, let's work with age, and we worked with ESI, which is the Emergency Severity Index. So we selected for sicker populations because we felt that they were higher at risk. So ESI 1, 2, and 3, meaning 1 is like in the process of needing almost ICU care because they're that sick, and 3 meaning that they have a serious illness in which they need more than one, diagnostic test or intervention. And what happens is that the triage nurse identifies the population. They get triaged to the geriatric rooms, and then the Epic Care Link actually triggers the flow sheets to start. So it's like your patient has been positive for geriatric ER, please start our flow sheets for protocols. And so it kind of walks them through step by step. All right, and now Taiichi is going to talk with you about the outcomes.
Thank you, Sarah. All right, so now let me talk about patient outcomes. So what happened on patient outcome after accreditations? So first of all, so our study period is very short. So I think it can be premature to determine the efficacy of this accreditation on geriatric patient outcomes. So here, what I mean by geriatric means age 75-year-old or older with ESI, Emergency Severity Index 1, 2, or 3. So inpatient mortality. So actually post-accreditation phase inpatient mortality rate is slightly better compared to pre-accreditation phase. So reason for this can be multifactorial. With our Geri ER protocol, it can build awareness of geriatric patient so that they can get more geriatric focused care, including RE referral to hospice, so that they can be transferred directly from emergency department to hospice. That may lower this number. Also, the actual care improvements, such as preventing fall and preventing catheter-associated UTI by reducing unnecessary use of Foley-cath, or like preventing delirium. Those like effort may reduce this number. And by geriatric education fair, the awareness of inappropriate medication, increase of awareness of geriatric inappropriate medication use for geriatric patient may be also contributing this number. Readmission rate, however, the post-accreditation phase has higher readmission rate. One of the reasons for this is that our patient population is aging and requires more frequent hospitalization due to progression of their multiple medical conditions. That may be contributing this number, but definitely this is an area of our area of improvement. Our intervention after geriatric ER screening may be not sufficient enough to prevent readmissions. Fall is a top chief complaint of emergency department revisit. So I believe fall prevention may reduce this number. However, evaluation for fall may be higher in our facility because we are the only level 1 trauma center on this island. So this can be challenging, but this readmission rate improvement is something we have to look for. All right, so next, ED length of stay. Actually, this is also getting longer. But as an ER physician, I know all the emergency department leadership are doing every effort to reduce this length of stay. Then actually, I know the ER registration time to triage time, and the triage time to ER doctor time, ER doctor time to disposition time, those times are actually getting shorter recently. But what is likely causing this prolonging length of stay is, I think, probably admission hold in the emergency department. Recently, so many patients are waiting in the emergency department to be hospitalized. I think that's prolonging length of stay. I think that being said, I think this 20.3% is not bad number. I think geriatric ER screening test in the triage and RE social worker intervention is preventing long ER lengths of stay. This number could be worse without our protocol. This is a completion rate of the geriatric ER screening. All the screening tests are actually improving. I will show you the number. So we got the accreditation in September 2018. The first 3 months of dementia screening completion rate was only 27.5%. But in the latest 3 months, it has been improved to 32.1%. ISR is same. First 3 months it was 26.4%, now 30.8%. So, and I also calculated sensitivity of those screening tests. ISAR is identification of senior at risk, basically screening test to identify physical function declining, and Ottawa 3DY dementia screening test. As a screening test, I think sensitivity is important, but especially ISAR has very good sensitivity for those bad patient outcome. Especially ISAR was sensitive at 90% on readmission in 30 days. That being said, if ISR is negative, that patient is very unlikely to come back to be hospitalized in 30 days. And both of tests are ultimately sensitive for any restraint event in the emergency department. Again, if those screening test is negative, almost impossible that patient get restrained due to their urine or agitations. So it's a good screening test. Specificity is not, those tests are not very specific for those bad patient outcome, but Ottawa 3DY dementia screening tests are significantly sensitive compared to ISAR. So, where do we go from here? Screening completion rates are improving, but are still low. Our education fair have improved the ER staff awareness of geriatric patient, which in turn will increase the completion rate, and so that we can gather more screening data. Currently, these protocols help us to identify who need interventions. But however, we are still working to refining what type of intervention will improve those adverse patient outcome. So our goal is to provide multidisciplinary intervention on high-risk geriatric patient to reduce revisit to the emergency department and readmissions and had a long length of stay in the emergency department. Fall and shortness breath are the most common chief complaint of a geriatric patient for ER visit. So we hope to establish further protocol that focus on the most common chief complaints and tailor those protocols to our different facilities. Thank you so much. Yes, not 24/7, but Punchbowl in a 24/7. West, it is not 24/7. I'm sorry, Punchbowl is 24/7. Yes.
West is until like 10 or 11 p.m.
A lot of this takes sort of investment upfront from the administration, giving you the person who fills out this application and pushes this things forward. How did the paying for chief securely, how did you get administration to buy into that?
I think we lobbied admin pretty soon after we started this process, and we actually wrote Danny in, who had some experience with that. And sorry, Danny, I'm going to put you on the spot because I know there was some rally that we like emailed and went to the admin, and we were searching for multiple sources of funding. Yeah, so.
I think the basic idea was, CEOs and CEOs like badges, and I realized part of it was meeting with police appropriations part and Jason Chang, who are the CEO and COO, sketching out how much the general cost would be, including IT and physical changes, estimated to be about $20,000 roughly, to the startup cost. A lot of positive benefits because it's system-wide, so not just our Punchbowl but West, but also our North Hawaii and Molokai sites became, so it's kind of like a system-wide initiative. It's really a big theme to kind of do system-wide initiatives. And then ultimately, it was hard to project the potential savings, reducing stay, third-day bounce back to those things. But I think it just makes sense that it's nationally accredited. There's good enough data that's published that does show some length of stay benefits and financial benefits that I think for the nominal cost to go in, it's about $15,000, $20,000 roughly for IT and some physical. Probably not the game. That's kind of how we got to it. They signed up pretty quickly.
So it sounds like you got the accreditation, you got the policy, but the real work, in order to get out, you actually have everybody screening and all that stuff. So it's the real work of getting the certification and that's only just the beginning. So do you have a time for
We meet every month, so one thing that was a strength that even the site reviewer noticed is that we have a really well-developed database in which our ER admin can pull data for us. So that's why we know what the chief complaints are, we know who is revisited, we know like how many got Jerry consults, how many got the screening for falls, for functional status, as well as dementia. And we even know the number of social work referrals as well that are generated from this because our database is pretty awesome. So we lucked out with that.
You said all these screening, is it the nursing?
Yes, so if they qualify for the geriatric ER, it automatically triggers. It's supposed to, we had to tie in IT in order to do that, and we had a few roadblocks along the way on how to get that triggered. So that's why we had to get IT on board permanently.
patient satisfaction outcome?
Not yet. So, but that's something for the future, definitely. And we also have our community liaison, so that role is kind of important too, in giving us the feedback from the patient perspective on how things are going.
And that's a great point. What makes it so rich is that something like this touches so many things, right? So for the kind of the encounters we can do with absolutely one of the things we look at. And then you take the legislative level, you have the Department of Aging that loves the idea that there's community hospitals that are now looking at how do you do these screenings as a touch point, right? Because they're doing these in community centers and daycare centers and all these things, but then I think we obviously know that probably one of the biggest touch points, at least the highest group of the population, exists in our ERs. That's actually by far the highest, touch point. So I think we've been working with the legislative team as well, and I think that just in the beginning too, how we can actually build it, maybe more of a comprehensive city, state program through the hospital system. We only touch, the Queen system only touches about 45% of the population. And again, I think ideally, this is a thing that we can kind of extend to all the sites. I think it's an idea that we all share just as well as saying that. But yeah, it touches so many parts, just not just beyond the patient quality of care, obviously, is the most important thing, but the other aspects of it.
Do you find it's challenging, so when they get the screening, and they say they dementia positive screening, but they're acutely ill, it's unfair, because they go on to cognizance, and this now becomes a problem like
So it doesn't populate to the problem list, but what it's supposed to serve as is a flag so that people pay more attention to them. And we're hoping that in the future it might change the way that our staff communicates with our patients as well as, their caregivers, because that's a huge portion of dementia care. And we're a bit cautious about the dementia screening because in the back of my mind, that may cause some unnecessary stress, but what it does is it triggers us to actually get social work involved early. So as a result, transitional programs are actually a really hot topic and a big thing right now. So we're blessed in our facility to have QCIPN, which is a team of social workers and nursing staff that provide outreach to any patient that's been in Queens in the past 30 days. So if there's any huge red flags that go up after our social work screen, they can actually be referred to QCIPN, where they can come into the home and do a better assessment to see what our patients want or need and get them hooked up with resources. In the community, other programs that do participate in that, I think all the hospices do as well, such as like Islands, Bristol, Hospice Hawaii, and St. Francis. But theirs is mainly their work is done by a social worker. So.
Just to add on Anne's comment, I agree it's not the best time to do a dementia screening, but on the other hand, a lot of primary physicians, we know how to do it. We know up to 2/3 of dementia is nested family. And so if nothing else, it just triggers to them to say, hey, when the patient's back stable at home, please screen them for this. But I agree with you, I wouldn't want that label to be put on them while they're affected probably delirious.
And delirium is actually one of the protocols that you can address as well. And we're already looking at that for the future because it's missed a lot of the time, especially a hypoactive delirium, and the outcomes are